introduce you to our speakers. Cristina Campos is the Chief Executive Officer at Guadalupe County Hospital in Santa Rosa, New Mexico. She has worked in healthcare since 1993, first as a hospital volunteer and community encourager under the Community Health Development Program, and later became Finance Officer for the Small Frontier Hospital. She later served as a member of the Clinical Operations Board of the University of New Mexico Hospital in Albuquerque. Ms. Campos received her MBA in Healthcare Administration from Regis University in Denver, Colorado. She currently serves as chairwoman of the New Mexico Rural Hospital Network. Cristina is a New Mexico delegate to the American Hospital Association Region 8 Policy Review Board, and in 2013 was appointed to serve on the National Advisory Committee for Rural Health and Human Services. Mandolin Cordova is the Director of Nurses at Guadalupe County Hospital. She is a native of Santa Rosa, New Mexico, and began working at Guadalupe as a nurse tech in June 2004. She attended nursing school at Lunar Community College in Las Vegas, New Mexico, Nevada, became an LPN in July 2004, graduated May 2005, and became an RN August 2005. In September 2014, she became Interim Director of Nurses and was fully appointed to the position October 2014. She oversees all aspects of nursing, including patient safety and clinical quality improvement. Maria Atencio and Glenna Losito became co-chief clinical officers of Cibola General Hospital in 2013. Both Maria and Glenna have over 30 years of nursing experience. Both are registered nurses with bachelor degrees. Glenna became a family nurse practitioner a few years ago. Glenna and Maria began as nurses' aides at Cibola after college. Then they went back to college to finish their nursing degrees at different places, worked at different places, but ultimately both came back to Cibola General Hospital. Terry Hill, Executive Director of Rural Health Innovations, will facilitate today's discussion. Now I'll turn it over to Terry and our hospital leaders.
Thank you, Kim, and welcome everyone. We have a really interesting discussion today about transitions of care. And I would remind you that this is part of our small rural hospital transition program, which is funded by the Federal Office of Rural Health Policy. We always like to express our appreciation to them starting out for their support. And kind of for those of you that may be new to this project, we basically do two types of intervention. One is a financial and operational assessment, which we do with a number of hospitals in various parts of the country, and the other is a quality improvement in transitions of care. So today we're going to focus in on this latter category, and we have two critical access hospitals basically that are going to talk about their experience. Partially they'll talk about their experience with this program and with this kind of the assessment that was done, the work that was done through our program. But I'm also very interested in getting to the core of what is happening in transitions. It's just really interesting because transitions, which is in the title of our project, implies transitions of care, obviously, and that is the transition of the patient from one type of service provision to another, sometimes within the facility and sometimes outside of the facility. And as you know, as we're moving more into this value-based system, transitions of care become extremely important, and we become responsible not only for the good work that's done in our hospital, but also kind of following the patient into other settings of care as well. Trying to diminish our readmissions for care, trying to provide, ultimate customer service, and so there's that type of transitions. There also is this concept of transition, which is more consistent with probably what the transition is in our title, which is it's a transition from the current fee-for-service or cost-based reimbursement system into what is rapidly becoming a value-based system. And that doesn't mean that cost-based reimbursement is going to go away. but it does mean, we think, that rural hospitals are going to have to think about and plan for their place in that value-based system. So I'm really delighted to have two really good hospitals here to talk about their experience, and we can get some feeling for both the first definition of transition and the second as well, the transition within their community and the transition of their hospital moving into different reimbursement system. So I'm going to start with Cibola first, from Chris and from Glenna and Maria, and I wonder if one of you would tell us a bit about your hospital.
Sure. This is Maria. You know, we have a beautiful 25-bed critical access hospital. It's about a 50,000 square foot building, and we have take care of everything here. We've got a good staff. They're dedicated, and we do surgery, general surgery. We have 2 general surgeons, an OB-GYN. We also have the ability to do some podiatry and dental in our OR. We also have an ICU unit. We have an LDRP that we staff, and a med-surg unit. We also have ancillary departments that are open 24/7, and so we're really lucky here at Cibola. We have lots of things to serve our community.
And could you tell us from a geographic standpoint where you are in New Mexico and how far you are away from other hospitals?
Okay. We're 80 miles west. We are critical access. We are 80 miles west of Albuquerque, which is the biggest city in New Mexico. We're at the base of about a 12,000-foot mountain, so we've got beautiful scenery here and lots of outdoor activity. We're nestled in, around us are 1, 2, 3, about 4 or 5 Indian reservations surrounding us. So we also have that as part of our community.
Yeah, we've been there actually, and it's just a beautiful area. I really recommend it to those of you that haven't been in that part of the country. It's just
it is
really,
very beautiful. Yeah. Lots of outdoor activities. Lots
absolutely.
Yeah.
So tell me a little bit about what was your motivation to participate in this program? As probably most of you know, we require an application process to come forward, and even though we don't charge for the services because they are provided by, through the contract that we have with the federal government to acquire the funding, we recognize that it still takes an expenditure of time, and that you folks have so much on your plate already that adding another project is not inconsequential. So why did your hospital decide to participate in this program?
I think that at the time we had a CEO that was really motivated, helped to motivate us for that. We were also looking for some quality, you know, how we can improve our quality, what we can do to help move our hospital, you know, so that we want to make sure that we're giving the best quality of care, all aspects of it. So after reading the application and everything, we thought that it would probably help us, you know, in moving that direction.
Was there any consideration, Maria, of kind of preparing? We're going to talk more about this later in the call, but was there a thought that the need to be able to document quality and have outstanding quality would prepare you for the future, or was it pretty much just a straight observation that you could improve the quality locally?
Oh, no. You know, if you're in healthcare now, you've got to be thinking about the future. And, you know, quality is on everybody's mind. We already had the initiatives going and in place and working towards. We know eventually that we are going to be paid for performance, that value-based will come our way. But more importantly, we feel like if we're doing the right thing for our patients, the right quality things, we're going to have great outcomes for them. And that really is our driving force. Anything that we do that, you know, propels quality or, you know, all
This
of
helps to improve our patient care.
we are very interested in moving that way. And this just kind of fit in right with the initiatives we were already doing, helped augment them to just keep moving us forward.
Okay, terrific. I'm going to now move to our other hospital, the Guadalupe County Hospital, and I assume Christina Campos is going to speak on behalf and tell us a little bit about the hospital. I just want to, again, point out in Kim's introduction, Christina is so involved, in terms of so many different projects. She chairs the Rural Hospital Network in New Mexico. She's a delegate to the American Hospital Association. She's on the National Advisory Committee for Rural Health and Human Services. So this is an individual who should really be kind of knowledgeable about what these larger organizations are doing, and also she would have a really good feel for policy considerations, particularly those in regard to rural hospitals. Christina?
Thanks, Terry. Now I have big shoes to fill. Our community is located on the opposite side from Cibola. We're 120 miles east of Albuquerque, on I-40 also, which is the old Route 66. And it's a community, the entire county only has about 5,000 people, so we're considered a frontier county with less than 6 people per square mile. The community of Santa Rosa itself has about 2,500 people. Our hospital is a 10-bed hospital. We have the ER. We've got 10 beds. I mentioned that already. CT scan, MRI capability, the lab, and a retail pharmacy within the hospital. We also have a pain intervention clinic to help address some of the opioid addiction issues on this side of the state. And we contract with local primary care providers to provide ED and hospitalist services. So we're kind of like a public-private venture. We are a standalone hospital, not affiliated with any corporations at all. We're county-owned and operated. So we're really, really small. We only have 38 full-time equivalents, and that does not include the doctors. We have a medical staff of about 8 right now.
And Christina, what was the reason, or what was the motivation for taking on a quality improvement and transitions to care project?
Well, we had 2 options. One was the option of doing the financial improvement or review, and the other one was the clinical quality care. We were already contracted to do a financial analysis, charge master review, and full review of our revenue cycle, so we didn't want to duplicate that effort. And we had high quality scores already. We had strong clinical quality scores and pretty high patient satisfaction scores. We were overall scores close to 90% on the HCAHPS for what patients recommended, and always in the top 10%. But I had a feeling that some of it was not hardwired enough. It felt almost like luck, or that it was personality specific. And there's always a concern because of the turnover in rural hospitals, that if we lost the people, that unless we were able to document it, make it part of policy and truly hardwire it, that we could easily lose it. So we just wanted to make it more solid, more official, and in a way institutionalize it. And this helped us get fresh eyes to come in and to look not just at what we were doing right, but where those opportunities for improvement were, and how to bring in better ideas and just keep the process going. Because as you notice, with quality improvement, everybody's doing it. And if you don't continue to improve, you'll get passed by. So it's important to up it up a little bit and go forward.
Yeah, and we really like this concept of hardwiring, that you can have dynamic leaders who are kind of leading the quality initiatives. But as you're saying, I hear you say, Christina, hardwiring is actually embedded then into the culture. And if you remove the dynamic leader, or the dynamic leader gets recruited away to some other big hospital, or they retire, or something of that nature, there's such a hole that's left there that often we see really declines in quality, productivity, et cetera. So I really like the idea that you're expressing about hardwiring it, because it kind of, it's almost like providing additional insurance to your future outcomes.
Yeah, and our hospital has a long history of being on the brink, like lots of rural hospitals. We had 11 administrators over a period of 11 years.
Wow.
And could never really reach a level of quality because the ground or the floor would be pulled out from us regularly. New Mexico also has a turnover rate in CEOs of about 30% annually. So like you mentioned, you don't want just leadership to buy in. You want it to be part of the entire system.
Yeah, absolutely. Okay, Christina, talk a little bit about kind of what happened. Who came, and just, if you will, rather than getting into the outcomes, could you just describe the process a little bit about how it looked, who was there, kind of a time frame, et cetera?
Sure. Well, once we were notified that we had received the grant, we did have to collect the data, our HCAP scores, our quality scores, financial measures, the different ways that we were gathering quality data and reporting it, and our quality improvement projects, and send it to the consultants from Stroudwater. Stroudwater had contracted with SRHT to do this analysis. So we sent them all the information, and they reviewed it before they came down. Then a few weeks later, two of the ladies, it was Carla and Mary, met with our entire staff. Our OPI, our Operational Performance Improvement Committee, is made up of every single department head in the hospital. And I, as CEO, am the head of quality. Quality is a really, really big deal to us because we are the smallest hospital in the state, and I guess to a certain extent we have a little bit of a chip on our shoulders that we don't want people to assume that because we're small, we're not super high in quality, so we really, really push the quality piece. And that's part of the reason why I head quality, that if, as CEO, I can't be the champion and leader of quality, it seems like I'd be doing the wrong thing. So we met, all the department heads met with Mary and Carla, had several discussions. She met with our doctors, and then started some improvement. To be honest with you, part of the process was painful. Criticism, even when it's constructive, hurts. So looking at ourselves and, taking off the blind spots, taking off the blinders, was a little bit of a painful process to see that, yeah, you're good here, but, you could be so much better. I think it was also an educational process for Mary and Carla to see that there was more than one way to get the project done, that it didn't have to be exactly their process, that there were ways that we could accomplish the goals by developing process that suited our staff and our staffing levels and our facility structure. But there was some give and take, and there was educating on both sides. So it was a big process, a long process, because even after they were done with their recommendations to us and we had set up our plans of action, we continued to work on it and chip away at it. So we didn't see it as a project, but as a continuous journey.
I really want to hit a point there that I think is really important, and I think something that has been learned from, we've now at our National Rural Health Resource Center, we've been doing these types of projects for close to 15 years, And I just really want to acknowledge the courage that it takes to bring people in from the outside. That way, I was, head of an organization for 27 years, something like that. And it doesn't matter how many positive things they say about you. Every negative thing is a reminder that you're imperfect and that you've got work to do in that regard. So what we find is the really good administrators kind of welcome people from the outside, are courageous enough to kind of accept that. And it isn't just the administrators. It is the director of nursing. It's the department heads, et cetera. And unfortunately, some of the hospitals in the biggest financial distress really may lack the courage to actually have somebody come in from the outside, because it's not only painful, but it's they just don't want to acknowledge that they're in that deep trouble, or very often there's nothing we could possibly do about it. We're tiny, small. We're only 10 beds, et cetera. So I just really want to acknowledge those folks that kind of open their doors to folks on the outside and listen. And it's not like you have to take all these recommendations, but you at least have to consider them. And again, we make sure in advance that there's that kind of commitment on the hospital before we do anything up front. I'm going to turn then to Cibola here and tell us a little bit about your experience, if you will, in terms of the consulting process. Who came and how did it go, et cetera?
Terry, I really appreciate that Christina's on this call also, because Glenna and I mimic her story, in that, we are small, and just because we're small doesn't mean we're not good, et cetera. The whole thing, from the painfulness it was to admit, they have lots of suggestions, and it's like, oh my goodness. But truly, if you take the attitude that this can only make us better, it does, and it can work. The process was, she described it. It was the same process for us spot on. And we did take their suggestions, and again, because we are different, every facility is different, we molded it to fit us, but with their recommendations, incorporated other initiatives that we were doing, and really made a go of it. And every month meet and see where we're at and see what we're going to tackle next, or, how can we make this. And we did learn lots of lessons from it. We learned that, where we need to work on even just making our leaders and providers, or whoever we were working with, making them accountable to our project and to what we were doing in our goals. It improved our collaboration with our departments to reach all of our goals. You've got to work together to meet them. It helped us to engage more staff, and through small steps all the way through, we got to the big goal, and we're continuing that.
Tell me a little bit, Maria, about, I understand that the CFO's involvement, the Chief Financial Officer's involvement was really very helpful. And from what I've heard, it took a while to kind of get him engaged, et cetera. Now, one of the reasons I ask you this is because our experience is that CFOs tend to be the most conservative folks in the leadership team, for good reason. That's who you want handling your money in that regard. But we feel that CFO leadership is essential because they're so influential within the organization, both on their input in terms of decisions to allocate money, for the follow-up or anything of that nature. So we are, in fact, holding next month a CFO leader or a financial leadership summit meeting where we're bringing in CFOs and financial experts from throughout the country to help us in terms of, kind of identify education, just information, et cetera, that would be persuasive to CFOs kind of in a dollars and cents standpoint, and particularly in regard of getting their support in this transition into value. So with that lead in, tell us about your experience with your CFO.
I think like the rest of us, just the apprehension of, like she's new project, new, how all the changes are going to occur and what we're going to do, how this is, but once you get on board, or once we're all on board, you all know that it's leading us down the road that's going to help us achieve, hopefully, financial stability. The transition that's occurring, or that we're all working on, all the goals we all are working on, we're working towards how to being sustainable.
And so you went through this process, and my understanding is there was the initial time on site, and then the team came back, is that correct, sometime later and kind of presented their findings and their recommendations. Is that correct?
Yes, that is correct.
Yeah.
Tell me a little bit about, what have been the outcomes to date? So you spent this time, this effort, you kind of opened yourself up, as you indicated, to outsiders coming in and helping, making recommendations, looking at kind of the basics of your operations, your processes, et cetera. What have been the results so far?
Well, we have picked several different groups. We chose ED throughput and transition. We chose UR, discharge readiness and transition of care, readmission prevention, and each of those is its own little team, and it has its own little key people on those teams. And with each of them, we had quite a big chunk of action plan, chose out 3 at a time, and then are just tackling each of those as we go along. And so, for example, ED throughput, right now we have, we've done different things like set in protocols for like pediatric temperatures, for abdominal pain, for fractures, etc., to help the flow of the ER. We've set up a room and bought some extra chairs so that we have this room that's not used in the day. And when we don't have any available beds in the inpatient area, we can move the discharge patients that are like waiting for rides and take them to this room while they wait to the ride, so we can get those patients up onto the floor quicker. I mean, there's been lots of initiatives and changes to help with that throughput. But each of those areas, we've tackled different processes to improve quality.
Outstanding. So in essence, the other thing I think, by the way, before I go any further, let me put in a plug for our newsletter, Timely Transitions, where the folks at Cibola were interviewed recently about the project, their outcomes, et cetera. So if you haven't taken a look at that, our colleague, our staff person, Rhonda Barkas, does a really good job of putting some really good information in place, et cetera. So do open that up and take some time to read it if you possibly can. But one of the things I saw also is that you became more data-driven here. And, my observation is that physicians in particular love data. So can you talk just a little bit more about that?
Sure. We've also developed a ER scorecard for our physicians, and then it lets them know about, what's happening with them. They're left without being seen, their transfer rate, their throughput, on and on. And, of course, it's a shock to them and very uncomfortable for, initially. But later on, then it becomes more, this is what we're, this is it. This is the data. And they can see, well, at first it was like, no, that's not how it is. But it's hard to refute the black and white data that you're giving on that. We've also extended that into our inpatient world, meaning the HCAHPS data that we're getting from our patients, we're now sharing that with our local physicians, kind of like a little scorecard. So they can be part of that. But data really does help drive change.
Boy, I couldn't agree with you more in that regard. In our own organization at the center has used a balance scorecard with kind of key measures of our own success, including customer satisfaction, which is obviously equivalent to the HCAHPS, et cetera. And again, I think what we've found is that in particular physicians, and your experience there with the docs is really very similar. There's this kind of a shock, so you have to be courageous enough to present it to them, but in essence, they thrive on data and information, and as long as it's valid, because they'll question what's your methodology, et cetera, it becomes very persuasive, and et cetera.
You bet.
So, terrific.
You're correct. You know, the other thing that we've really worked on is to engage our physicians in what we're doing, in the data, and it really just makes for a stronger team.
Yeah, absolutely. Thanks. Okay, turning to the Guadalupe Hospital, Christina and Mandolin, what have been some of the outcomes since our crew was in there, since Carla and Mary met there, since you started to implement the recommendations coming out of that consultation?
Hello, this is Mandy. We don't have teams, so the nursing staff is our team. We did update our utilization review policies. We were kind of low on our discharge planning, so what project we did with that is we got colored folders. On admission, the patients are given these colored folders according to their diagnosis. In their folders, it's a bunch of teaching, which the patients are taught throughout their whole stay. There's a letter from Christina welcoming them. There's a vital sign sheet for them, a med list sheet for them. These folders they can take home. We have them keep all their stuff together, and then that way they can bring these folders to doctor's appointments, follow-up appointments, anywhere. That way all their information is in there. So we have seen that has helped us a lot with the discharge process. Also, we teach back. We emphasize the importance of the teach back with patients. Anyone can read the discharge off of a paper. So we have the nurses change the way they were discharging these patients, changing as to questions they were asking them. The nurse would go over it and then ask the patient, okay, so what is this medication for? The patient would tell us, okay, how often do you take it? When do you take it? So just kind of different things like that we have noticed has helped in our discharge process.
And our discharge scores on the HCAHPS actually went from the high 60s to the high 80s. So we went from about a 68 to about an 89.5.
Wow.
So it showed like an immediate response that the patients right away felt a lot more comfortable about going home and taking care of themselves. We kind of have funny stories to tell. We always, even in our old facility, we had fairly healthy satisfaction scores, and it was a 1952 Hill-Burton facility. When we came over to the new facility, at that point the question on HCAHPS was, were you ready to leave? Now you have to understand that we live in a very impoverished community with substandard housing. So they came here to this brand new facility with beautiful bathrooms and woodwork and views, and frankly, our scores went down. Nobody was ready to leave. So we were really happy when they changed the question to, did you feel ready to take care of yourself at home? Because really that was our goal, was get the patients ready and healthy enough to go home, and then educated enough to know how to continue to take care of themselves. And then when we talk to the nurses about the importance of this, it's and that ties into the CFO issue. I mean, everything is going to be tied to reimbursement in the future on your value-based payments, reducing readmissions. It's not that we don't love our patients and look forward to seeing them in the future. We want to make sure that they didn't come back because we didn't do our job well. And education is very important, as well as they're educating us on their standard of living at home, whether or not they can afford the prescriptions, do they have trouble reading, do they have trouble getting back to the doctor. So it's a two-way process that teach-back method is able to identify either issues of our not teaching them well enough or issues of deficits that they may be experiencing that makes it difficult for them to continue their care at home.
Yeah, I really like that concept. So in other words, what you're doing is you're customizing your discharge planning. You discharge somebody to an expensive house or into a really positive setting, and that's one environment. And the other environment is you're discharging them into a setting where they may not have some of the basics, including transportation in that regard. So what I hear you say, yeah, go ahead. Yeah, it is that personalized. That's the great thing about rural hospitals is that in a big city like Albuquerque, for example, you can do a lot of that, but you can't do the kind of exceptional job that is possible in a rural community because the community is so much better in that regard. In terms of, again, Phil, from the Guadalupe Hospital perspective, what were some of the biggest things that you learned? And anything in particular, you've already described some of the barriers that are out there. I'm just trying to get, what were the lessons learned going through this process?
One of the things that we learned and that we shared with the consultants was the importance of how you deliver the message. How we as providers deliver the message to our patients and their families, how we as leaders deliver the message to our employees and our team members, and also the importance of how the constructive criticism from the consultants was delivered to us. In any step of the way, you can't be condescending. If people feel that you're talking down to them in any way, whether it be the consultants to us to our team members, or the team members to the patients, you immediately get a disconnect and a refusal to listen. So communication is just so incredibly important. And then also looking at all of it from the opposite perspective. There were things that they recommended to us that at face value sound really, really good, but really were either financially impractical. It's like saying we're going to, install this, $60,000 piece of equipment so that we can save $10,000. Or we're not seeing any problems here, but we're still going to, implement the latest, greatest, most expensive program just in case in the future there's an issue. So we really had to weigh the benefits, both in terms of financial dollars and time expended. So it was a good lesson for us to make sure that everybody is heard, everybody gets to contribute, and that the different perspectives are really looked into carefully.
That's a really good distinction too. And I guess I hadn't really thought of it that way in that regard. To some degree, I just mentioned the importance of kind of customizing your message to your patients during discharge, but what you're saying is that it's really important for hospital leaders when they have consultants coming in from the outside to weigh their advice given their circumstances in that regard. And there's absolutely no way Mary and Carla could know your community, know your hospital as well as you do. And our experience and what I'm hearing you saying is that they're giving you these recommendations, but they're not telling you to do these things. They're saying these are important things that we think you should consider, but ultimately leadership of the hospital is going to have to determine, you're going to have to determine where you want to put the money and where you want to do some of these other things. And in our opinion, if you simply took the recommendations as gospel and tried to do them all, particularly at the same time, it would be very unproductive in that regard. So, we try to choose consultants who kind of walk the walk and besides the talk sort of thing. And it is important, and what we hear over and over again, and I'll see if the Cibola experience is similar, is that it's then up to you to kind of choose which ones are most important and which ones you want to implement. Okay, with that, I'm going to turn to Cibola again and tell me a little bit about, again, kind of what your outcomes are and what you've learned, or kind of what you've learned in general. What were the key takeaways from your experience?
I think one of the things that really helped us a lot was on our transition of care was we involved other departments, and we got pharmacy really involved. Our pharmacy right now see every patient that's discharged and go over medications with each of the patients so that they understand, what exactly the medication is, what the side effects are, and have had patients that have come back just to talk to our pharmacists about if they didn't understand it. And I think pulling in the other ancillary departments in, whenever we were going to make changes or recommendations so that the patient had a better understanding of when they went home and what they were to do when they got home. Because, when you discharge a patient and you go over everything the discharge, most of the time they hear maybe a few words of it, and when they get home it's when they have all the questions. And so, and especially about medications, especially our Medicare patients, they're on 10 pills, and so we change it. We're taking some away, adding some new ones, changing the schedule of it, and so expecting them to understand that, I think, and then getting pharmacy involved with that and everything, that really changed, I think, our transition of care for discharging on our Medicare patients with that kind of type of thing.
Do you have an in-hospital pharmacist, or tell me a little bit about your pharmacy situation?
Yeah, we have two pharmacists that work during the week and one that works on weekends. They're here from usually about 7 in the morning until 6 in the evening, and then after hours they're on call. They don't usually have to come in because we have Omnicell that our nurses are able to pull out all the medications from, and most of our discharges are during that time that they're here, so they will go and see all of the patients that are going to be discharged. And we have right now we have a really nice working group, pharmacy working well with nurses and the physicians. They come in the morning and talk with the physicians about antibiotic therapy, any of the levels or anything like that that they might have questions about, and kind of just discuss the patient. So, right now it's really working nice.
Yeah, and what I'm also hearing you say is that in essence we're moving kind of towards more of a team-based approach as such. And again, we've been hearing that pharmacists become important members of the team, so you're kind of reflecting that, particularly given all of the the issues with drugs and drug interactions, and we could go down the list on medication safety, etc. So
sorry, it's Maria.
Oh, go
and
ahead.
A lot of things that we're doing, we've joined an ACO, and where our launch is going to be March 29th, our ACO launch, and a lot of everything that we have done, over this past year also has helped us prepare for that. And that too has been kind of an apple in our eyes, looking towards the other projects that we have going on. And so like Glenna explained, the transition in care with the Medicare patients, it's going to fit right in with our new notebooks and with our new patient care coordinator and assisting her as we move forward with our ACO.
So I'm glad you brought that up. So you are going to be a part of one of the new ACOs that have been launched by the National Rural ACO. Is that correct?
Yes.
Okay. And that means that you are either designating somebody or you've got a care coordinator. Have you hired that care coordinator?
We sure have. Yes, we have.
Oh, okay, yes. Terrific. And you're launching.
Right, we're well on our. Yeah, our launch is March 29th.
Okay, terrific.
Preparing for quite a while. Trying to get up to speed. It's unknown territory for us all. And so, we're excited about it, and, here we go.
Yeah, absolutely. And with the availability of AIM funding, which was money the federal government made available as forgivable loans, we've seen a huge increase in the number of rural-based ACOs. Mm-hmm. As of January 1st, there were 41 new rural ACOs that were launched, and you're one of those. You're part of one of those 41. But that basically will include hundreds of rural hospitals and clinics, and it's a great adventure. But tell us a little bit about, because the last segment here, I'm going to focus a little bit in terms of how you see what's going to be necessary to be successful as an ACO. I think you've already indicated, Maria, that quality improvement, for those of you that aren't really familiar with this, quality improvement is actually a absolutely essential part. There are certain quality indicators, quality levels that you have to meet in order to be eligible for any of the major financial rewards here. So just talk briefly about what do you see as the hospital's moving forward? What are the key things that you're going to have to do to be successful in the coming year with your ACO?
I think the key thing is going to be physician buy-in. The ACO isn't the patient but the physicians. And so that's going to be key, getting everybody on board. We do have a joining clinic, and, we are working towards not making their lives more difficult as we move forward with this ACO, but to try and show that, be a partner with them in helping to take care of their patients and helping to keep their patients healthy. And so I think that's going to be our big selling point.
Yeah, I do. Mm-hmm.
Right, and you very accurately put your finger on one of the real major variables here. As we look at what are the critical success factors for rural accountable care organizations, physician involvement, physician buy-in is close to the top of the list. Just as an aside, our center is also doing a rural provider leadership summit looking specifically at this issue and how we might help to support hospitals and clinics be successful in physician involvement and physician engagement. But yeah, that's obviously another very crucial part. So actually, the third piece, I would say, you've hit all the the major pieces here to some degree. Is that financial? You really got to sustain yourself financially as such. So the CFO's involvement, I think, not only in quality but in the ACO is absolutely going to be crucial. Mm-hmm. So great job. Sometimes I personally get concerned that a rural hospital, some of our rural hospitals may be jumping into this without realizing the need for this strong quality focus and efficiency, et cetera. But you guys obviously have got that message and moving forward. Christina and Mandy, could you give us a perspective? Kind of the last question I'm going to ask you is, how do you see that you're preparing yourself for value and whatever is going to be happening on the ACO side? What would you see? I think I heard from you that quality is really going to be important. But,
yeah, and across the board, I mean, when you look at the, hospital-acquired infections, you look at readmissions, you look at complications, ventilator-acquired pneumonias. I mean, everything that we're measuring for the CART, for the or the PQRS, the HCAPs. I mean, all of it is tied to reimbursement at some point or another. So we see it as all one whole. We didn't choose to become a member of the National Rural ACO at this time. We kind of dipped our toes in it back and forth. But because our physicians are not employed and they're private for profit, creating that partnership was going to be a little bit trickier. However, we're implementing everything that our colleagues across the state are in terms of quality, in terms of cost reduction, streamlining, to ensure that at any point, if this were to become the way it's going to be, we're more than well prepared. It's almost like being the best version of ourselves that we can possibly be, so when time comes to either align with somebody, coordinate, or partner with anybody, we will be a welcome team member because we're good at everything that we do, financially and clinically. So we will be prepared no matter what.
Yeah, that is very well said. Again, rural hospitals don't have to become ACOs at this point to be viable in the future, but they have to prepare to provide value, we believe, and that's what I hear you saying, is that the timing needs to be right, and in the interim, we're going to do everything we can to maximize their cost effectiveness, our patient safety, et cetera. And then my thought is that hospitals who take that attitude and act upon that kind of a commitment are going to be very well off in the new environment. I firmly, just get my opinion here, believe that rural hospitals are going to do well in the future and value-based as long as they prepare effectively.
Yeah, and I think like when we talked about the process versus the goal, there's more than one process. There's more than one way to get where you're going, but the goal is quality across the board. We're definitely committed to it from a board perspective, from a provider perspective, community perspective. The community is really well aligned with what we're doing. We just completed a community needs assessment, and our feedback was really, really positive in terms of what we do and how we do it. We don't claim to be all things to all people because we're really small and serve a very small population, but we aim to be the provider of choice for anything that we do provide.
Outstanding. Does anybody have any questions they'd want to bring up, or they can type it into the chat box? There's at least a few minutes if those on the phone want to ask a question.
And
you're also welcome. Go ahead.
All right, I was just going to remind everyone it's *2 to unmute your line. Terry, Roberta Jeffrey has a question. What is your experience working in a small hospital regarding splitting your time between patient care duties versus administrative duties? What percentage is spent in each area?
I'll throw that out to our panel.
Well, this is Maria. For Glenna and myself, it just depends on what day of the week it is. We are a small hospital, and so we do work in every area. And if we've got, recess, if we have a baby that we need to attend to, et cetera, it just depends on what's going on that day. So I can't even estimate a percent. Do you, Glenna?
No,
We're up and down all day to get the job done. So And the same with, education that we do for the staff, et cetera, because we do the nursing education also. It's just kind of our jobs are many, and we just split them up wherever the need might be for that day. So I'm sorry if that's not a good answer. I don't know a percentage.
Yeah, and I think it also depends on where on the timeline people are with their electronic health records, how easy they are to navigate, how much time you're spending documenting. But there is a substantial amount of time that is spent at the computer. So we try to tell the staff to spend as much time as they can at the bedside, make sure that their shift change reports are at the bedside. It's so important.
Also, we have about 4 or 5 computers on wheels that we have the nurses take in with the patient. As they're doing their assessment, we have them document their assessment right away.
We try to get them to spend as much time as
with
they
the
can.
patient.
Yeah, and that's the way we do it too. We have computers at the bedside. Again, same theory.
Any other questions? Kim, any last-minute announcements?
Last-minute announcements. Well, first of all, I'd like to thank all of our speakers today, and thank you, Terry, for facilitating. You can read more about Guadalupe and Cibola Hospital in the hospital spotlights, which you can find on our website and Facebook page, or you can click the link on the screen. The recording of this call will be available on our PMG Playbacks page later today. You can register for any of our upcoming webinars by clicking the links on the screen. And at this time, I'll ask that you complete the short online assessment of today's call. If you have any questions or comments, please contact me at the email link on the screen, and I hope to have you all on future calls. Have a good afternoon, everyone.
Hi, everyone. Thank you.
Thank you.
Thank you.
This conference is no longer being recorded.